Hey everybody, and welcome back to another video. Today we're going to be talking about intra-aortic balloon pumps, or IABs. These are hemodynamic augmentation devices. This is going to be somewhat of a more advanced or complex lecture for those who are more introductory to the subject. We will do our best to kind of provide adequate background as well as dive into the specifics. But if a few things are kind of above your level of understanding, feel free to ask some questions in the comments so we could try to clear things up. So intra-aortic balloon pumps. What are they? How are they inserted? What do they do? Well, it's a hemodynamic augmentation device, meaning that it assists the heart in pumping blood, and as doing such, it can help both kind of the peripheral circulation as well as the heart itself. So I want to first talk about how you insert this device. I then want to talk about how it works. We'll go into the hemodynamic results of that, and then we'll go into indications, routine care, complications, and contraindications, okay? So inserting. So this device is usually inserted, oh, I don't know why that jumped over like that, usually inserted through the femoral artery. All right, the femoral artery is the artery in the groin. So what we have here is our heart, which we didn't draw, ascending aorta, aortic arch, descending aorta, into the common iliac arteries, and you insert this into one of the branches of this, the femoral artery. If you cannot insert it through the femoral artery for whatever reason, you can do a subclavian or axillary artery approach, and those are the subclavian artery comes off the aortic arch, and then the axillary artery is near the armpit, whereas the subclavian is near the clavicle. So you can insert it through those arteries as well if you can't do a femoral approach. So what they do is they use an 8 French catheter sheath, and they insert this balloon pump up through the femoral artery into the common iliacs, into the what is the descending aorta, although we're going upwards, towards the aortic arch. And they want the distal tip of the balloon to be 1 centimeter from the left subclavian. So this here is the left subclavian artery coming off the aortic arch, and you want the tip of the balloon to be 1 centimeter from that. All right. Now, what does this do? Well, it actually is a balloon, and as a balloon, it inflates and deflates. So the goal is to inflate right after the aortic valve closes. So directly after aortic valve closure. And we'll talk about why, for those of you who are thinking about why that would happen. And then we want it to deflate, all right, right before aortic valves opens. Now think about what this would do for the blood flow out of the heart, right? Because the blood flow is out of the left ventricle past the aortic valve into the ascending aorta to the rest of the body before aortic valve opens. So what this does is it essentially augments the diastolic pressure. So why is that? To understand this, I'm going to draw an arterial line waveform, which typically looks like this. All right, and what do we have? What are the parts of this waveform? So here, this upstroke, we have the systolic upstroke. So an arterial line goes in the artery, and it measures the arterial blood pressure, and it creates a wave based on that arterial blood pressure. So the systolic upstroke is the increase in pressure that occurs in systole when that left ventricle contracts and shoots blood out of the ventricle. Okay, this portion here is the systolic downstroke, and that is, you can see obviously an elevated pressure above baseline, but the pressure is starting to decrease because systole is getting towards its end. So the pressure is starting to come down, even though you're still in systole and the left ventricle is still contracting. Less blood is coming out, and thus less pressure is being created. This here is the dicrotic notch. And let's write that out, dicrotic notch. And that is when the aortic valve closes. All right? And that's when you enter diastole, and that's what's going on here. This is the diastolic runoff, right? So after the aortic valve closes and you get a little kind of bump in pressure because that aortic valve closes and thus increases the pressure past the aortic valve. And then after that, the left ventricle starts to expand and you get diastole where you get this diastolic runoff. Okay, so that's a normal arterial waveform. Okay, and we'll just write that. This is an arterial waveform. So what happens then when we put in an intra-aortic balloon pump? All right, or an IABP? Well, that tracing changes a little bit. It actually starts to look like this. The systolic upstroke, dicrotic notch, then diastole, and that comes down. And that is in accordance with the waveform of the intra-aortic balloon, and we're going to go over all this, which looks like this. You get this up here, and then it plateaus down, and then deflates the rest of the way. All right? This point is inflation, which is why you get that increase in pressure. And then this point is deflation. So if we look at, and this is the intra-aortic balloon pump waveform. So if we look at the arterial tracing, all right, and we see now that you have the systolic upstroke dicrotic notch, but instead of having, let me mute my computer there, instead of having the diastolic downstroke and systolic downstroke and diastolic runoff, you actually get a diastolic pressure that goes higher, and this is the diastolic augmentation of the balloon pump, because the balloon pump inflated, right? The balloon pump inflated, and by doing such, it plugged, you could think about it, this area of the aorta during diastole so that the pressure in the heart stayed higher, right? The pressure that you're seeing in the arterial waveform, the diastolic pressure stayed higher, all right? Because you don't get that diastolic runoff because you've plugged the aorta here. All right, I hope that makes sense. If there's questions, please ask them in the comments and we could tease it out a little bit. So you expect the arterial waveform to have diastolic augmentation in the arterial waveform tracing, and that is because the intra-aortic balloon pump, which you can see the inflation and deflation that occurs. And when deflation occurs, you get kind of this little blanch and then the rest of it runs off. So how does this change hemodynamics? That's, the question. Why are we doing this? So hemodynamic changes, and we'll do change as a triangle, delta, hemodynamic changes. Well, we could, conceptualize that the blood in the proximal aorta gets displaced during diastole when the balloon pump inflates, right? And as such, you augment, as we said, that diastolic pressure. Because the balloon inflates, plugs that proximal aorta, and increases the diastolic pressure because the balloon is inflated in the aorta. And it can do so by, as much as 30% increase. The other thing this also then does is it increases coronary perfusion. Why is this? Well, if you all remember, your coronaries get perfused in diastole, right? So your coronary arteries kind of come, right off in this aortic root, and they go to the heart. So if you're increasing your diastolic pressure and increasing the amount of pressure that we see in this aortic root, you're going to get more blood flowing in those coronaries. So you're going to increase coronary perfusion. Now, to be fair, studies are variable in terms of whether this does actually occur and by how much, but the typical teaching is you increase your coronary perfusion. All right? The other thing you're going to do is you're going to decrease your aortic volume in systole. Now let's dive into that a little bit, right? So systole is when your heart, your left ventricle, is contracting and pumping blood out. So if you have this inflated balloon, why would you decrease your aortic volume? Well, you're actually deflating the balloon right when that aortic valve opens. And as doing such, you get this vacuum effect. And the vacuum effect actually unloads the left ventricle and decreases the left ventricle afterload. And the afterload, right, is that pressure outside the left ventricle that the left ventricle has to pump against. So you're decreasing. This balloon inflates really quickly, deflates really quickly right when that aortic valve opens and creates a vacuum effect. And as such, you're going to have more blood flow because you're decreasing the afterload secondary to that vacuum effect. And you decrease the afterload by about 20%. So you're also offloading the left ventricle. So kind of the summary of the hemodynamic changes are you increase and augment the diastolic pressure, that increases coronary perfusion pressure, and then the deflation of the balloon creates a vacuum effect that decreases afterload, thus unloading the left ventricle as well. Now, one thing to note is that the worse the left ventricle function is, so worse LV function, the less effective, so decrease effectiveness, the less effective an intra-aortic balloon pump is going to be, because you do need left ventricular function. Even if you're offloading the LV, if the LV isn't working, you're not going to have as impressive as a result from an intra-aortic balloon pump. Okay, so that's kind of the physiology of it, both from a conceptual standpoint with hemodynamic changes as well as from an arterial waveform standpoint. Let us know what thoughts, kind of questions you have in the comments, and we'll dive into indications, contraindications, routine care, and complications. Okay, so you have your intra-aortic balloon pump. What are the indications? Well, the indications, we can think of based on the function, the hemodynamic changes that occur with it. So if you have refractory myocardial ischemia, so what does that mean? That means your heart isn't getting enough coronary perfusion and you have refractory ischemia. And this is those kind of waiting for definitive therapy who have a complex, coronary disease that needs more definitive advanced therapy that might not be able to be given at that moment. You can put it in an intra-aortic balloon pump. Why? Because as we talked about, it increases coronary perfusion pressure to try to optimize that myocardial blood flow and decrease the ischemic burden. All right. Another one, which is kind of the most common, is cardiogenic shock. Cardiogenic shock is when your left ventricle, or your right ventricle for that matter, isn't pumping well enough, and it leads to hypotension and organ damage because you're not perfusing those organs. Now, this is specifically used primarily in the USA because there was a trial called the Intra-Aortic Balloon Pump shock trial, and I believe it was shock 2, that showed that there was no mortality benefit at 30 days or 6 years using intra-aortic balloon pumps for cardiogenic shock. But in the USA, we still do it. All right? Another one which is related to number 1 is high-risk PCI. PCI is percutaneous coronary intervention. It's when you have clogged coronaries and had a heart attack and you have to go in and clear those coronaries out. And if you have a high-risk PCI and you're worried, because someone has a decreased left ventricle ejection fraction, so their left ventricle isn't pumping well enough, or something like severe multivessel disease, and you have to go in and fix that, and you're worried that they may not be able to tolerate the procedure, you can put in an intra-aortic balloon pump for the procedure to help bridge them while you're fixing things. All right. Another one, if you have a refractory ventricular arrhythmia, so your ventricles aren't contracting appropriately because they're not getting the appropriate electrical signal, and because of that, you're getting end organ damage. You can put an intra-aortic balloon pump to try to augment that left ventricle ejection fraction. And then the last one here is refractory heart failure. So you have really bad heart failure where your heart isn't pumping well enough. You can put an intra-aortic balloon pump to try to, augment that cardiac function until you're able to kind of get a more definitive therapy. All right. So, with high-risk PCI, I did just want to mention one more study. For high-risk PCI, there was the BCIS1 trial, it was called. And this trial showed no major adverse cardiac or cerebral events at 28 days, and there was an all-cause mortality benefit at 51 months with the intra-aortic balloon pump, which is why this is a more accepted indication rather than this one where the intra-aortic balloon pump shock true trial didn't show any mortality benefit. All right, so we talked about indications. What are the contraindications? So when are you not able to use this therapy? Well, that's a question. There's hard contraindications and relative contraindications. The hard contraindications are severe aortic regurg, AR. That's when your aortic valve's super leaky, and the balloon pump wouldn't be effective, right? Because when this balloon pump would inflate to augment diastolic pressure, if your aortic valve, it doesn't sit this high, but just for the sake of the picture, was leaky, all this diastolic blood flow would just regurge back into the heart and cause more damage than it was helpful. So severe AR is a contraindication. In addition to that, aortic dissection. So if your aorta has a dissection flap, so the vessel itself is damaged, you don't want to put a big balloon in there and risk aortic perforation. Another one, 4 or 3, is coagulopathy. So if someone is unable to get a significant amount of blood thinning medication, which we'll get into with routine care. 4 is severe peripheral artery disease, because putting in this device, you are going to have challenges with peripheral perfusion, and you can get ischemic limbs from it. And then 5th is just sepsis, which is a systemic infection. They wouldn't recommend intra-aortic balloon pump therapy. All right. So now we'll go into routine care and then talk about complications. So routine care is, fairly, well, I shouldn't say that. There are a few things that you just have to remember to do, and if everything goes well, those things can be, fairly quote-unquote routine. You want to get daily chest x-rays. Daily chest x-rays make sure the intra-aortic balloon pump is appropriately positioned. All right. So you want to do that daily to make sure it hasn't become dislodged. And remember that positioning is 1 centimeter distal to the left subclavian. In addition to that, you want full anticoagulation AC with heparin, because having a foreign object in your aorta can lead to blood clotting, thrombosis, and emboli getting thrown both to the legs and to the brain. And you obviously want daily labs to monitor. All right, and then you want to be doing pulse checks to make sure the extremities are staying well perfused in the setting of the possibility for embolism, as well as the contraindication of severe peripheral artery disease. All right, last but not least, complications. The complications are related to a few different things. We can kind of divide them into certain categories. One is vascular complications. All right. Vascular complications specifically can be divided into a few different things. One is limb ischemia, so not enough blood flow to one of the limbs. This usually is secondary to inserting the intra-aortic balloon pump through the wrong artery, such as the superficial femoral artery. It can cause damage to that, and then limb ischemia. Another one is vascular laceration. So while trying to insert the device, you can actually lacerate or damage one of the arterial vessels, which can lead to a lot of bleeding. And then the third one is ischemia to the spinal cord, actually. So if you, block off some of these spinal arteries from the aorta, you can lead to spinal cord ischemia. And then you can also get ischemia to the mesentery, or the gut, for the same reasons. All right. This usually occurs in 6 to 25% of cases. So it's, unfortunately fairly common. And then the other grouping are just other complications. And these take root in a few different categories. One, you can get cholesterol emboli. So cholesterol is obviously a fat, and it coats arteries, it's part of peripheral artery disease, and you can dislodge that and shoot little showers of cholesterol emboli throughout the arterial system, into the fingers, extremities, brain, etc. And you often will see thrombocytopenia, which is low platelet count, livedo reticularis, which is a skin finding, kind of a web-like rash pattern on the skin, and then eosinophilia, you usually have increased eosinophils. And believe it or not, you actually want to stop the anticoagulation if you start to suspect cholesterol emboli, as it can exacerbate things. All right, another thing here, you can get strokes, cerebrovascular accidents. If you dislodge a thrombus while inserting the intra-aortic balloon pump, it can actually shoot up into the brain and cause a stroke. Another one is sepsis, right, which is a systemic infection in the body, especially if it's in place for more than 7 days. All right. And then the last category is kind of a smorgasbord of things. You can get hemolysis, which is lysis of red blood cells, given that there's a device in the bloodstream. You can get thrombocytopenia, which is low platelets, as they're consumed, as again, there's a foreign cytopenia, foreign object in the bloodstream. And then you can also get skin infections in the area where it's inserted in the groin, because you have something that continually is coming out of the vessel in the groin, and it's kind of an opening into the body. All right, I think that covers kind of introduction to intra-aortic balloon pumps. Let us know what questions, thoughts, comments you have down below. Thanks for checking out the video. We appreciate you. Stay well, and we'll see you next time.